Good evening, everyone. My name is Egina Makwabe. I'm the consultant nephrologist working in Tanzania with Africa Healthcare Network. Yeah, so I would like to welcome you all into today's weekly nephrology webinar. I'll be chairing this session together with Dr. Frida Mowo, who is the consultant nephrologist. Working with, it's a senior consultant nephrologist working with AHN, Africa Healthcare Network here in Tanzania. So we have the panelists, Dr. Lloyd, Dr. Amar, Dr. David Mwaipaya. Today's topic is radiocontrast nephropathy, preventing the perils. It's a very important topic, especially during diagnosis and treatment of some of the medical conditions. I would like to introduce today's speaker. It's a great honor to introduce our speaker, who is Dr. Swapnil Hiremath. He's Associate Professor, Faculty of Medicine, University of Ottawa, and Associate Scientist, Clinical Epidemiology Program, Ottawa Hospital Research Institute in Canada. He's also a staff nephrologist, Division of Nephrology, the Ottawa Hospital in Canada. And he's a certified hypertension specialist by the American Society of Hypertension. He holds a master's in public health at Harvard T.H. Chan School of Public Health. So it's a great honor to welcome you, Dr. Swapnil, for today's presentation. You're welcome.
And thank you for that kind introduction. And I hope everyone can see the slides. In the next 40 minutes or so, I like to talk about something that I'm passionate about, that is contrast and the kidney and what is left to enhance. So that's what you see on the top left is the city of Ottawa. We have it's a very nice, beautiful city. Whenever you come by, feel free to drop in, and we can hopefully meet each other in person someday. So in terms of disclosures, I don't have any financial conflicts of interest from any drug or device manufacturing. I do have a grant funding from some peer-reviewed agencies. And I'm a member of the Canadian Association of Radiology Guideline Task Force, but the opinions that I'm expressing today are my own. And I won't be talking of any off-label use of drug or devices. And these are the objectives that I set for myself in the next, just over half an hour, to discuss the mythology of contrast-induced nephropathy, to understand what works and what does not work to prevent this from happening, and some practical discussion about, what do you do when your patient is getting contrast? If there's time allows, I can talk about mucomist, but even if the time does not allow, there are some slides at the end that you can view at your own leisure. So, again, I don't want you to vote or anything like that, but just think to yourself, right? This is something that is written in most papers which talk about contrast-induced nephropathy. They say, the first sentence often is that contrast-induced AKI is the third most common cause of AKI. If you read any review paper or any trial, also this is commonly written. On the other hand, a lot of people have now started saying that contrast-induced AKI is a myth, that it doesn't even exist. There is no such thing as contrast. There are very, very two contrasting statements, going from it's very common, it is the third most common cause of AKI, to now people are saying it is not, it doesn't even exist, it's a myth. So why is this discrepancy? Why are people saying things like that? So let us see where this third most common cause of AKI literature is. It's really one study. So it was done by Susan Hu in Boston. And what they did is they looked at some patients. This is from 1953. So it's a really old study. And they looked at 129 patients who had, at that time, what was known as acute renal insufficiency. And if you see what is going on here, so this is 1983. They all use the high osmolar contrast media. And out of the 129 patients, there were 16 patients who had possibly had contrast media exposure. So 54 were pre-renal, 23 had post-operative AKI, and 16 had contrast media. And, again, if you look at the causes, cisplatin and aminoglycosides, we don't see that so commonly anymore. So this is really a different era. And we should not be extrapolating these data from 4 decades ago to saying it's the third most common cause of AKI. We no longer, use contrast without any without knowing about kidney function anymore. So it's very, very unlikely that it is the third most common cause of AKI anymore. So, and the other thing is that in many of these studies, so if you see in the previous study, there was no control group. So how do you know whether contrast really caused AKI if there is no control group? So often what you do is, oh, you have a patient who had acute kidney injury. You look back, you see that they had received contrast, and you say that, oh, they have, the acute kidney injury was because of the contrast. But if you see that, often that a patient will receive contrast because they have sepsis or because they have cardiogenic shock or something like that. So if your patient has sepsis and cardiogenic shock, and that is why they are having a CT scan, or that is why they are having an angiography, it's really, the contrast is not causing the AKI. The reason why you gave contrast, the reason why the contrast induced study was done is what is possibly causing AKI. So the terminology has sort of shifted to saying, instead of saying contrast induced AKI, they now say contrast associated AKI, and that kind of takes the causation away. So you don't have to, worry about whether it was because of contrast or not. It was, it was associated. You cannot really say necessarily that it was because of the contrast. So this is one thing to keep in mind, is that when you see a patient, make sure that, you're ruling out all the other possible causes why they may have had AKI, and then only you can say it is contrast is causing this. On the other hand, if you look up, this is something you will often see. Contrast nephropathy is a myth. This is from Josh Farkas, who writes beautifully otherwise on the EM Crit blog. So why do you say that? But it's very easy to disprove this, right? How do you, when people thought that swans were only white and no black swans existed, all you have to do is to show that there is one black swan, and then you can prove that it is no longer a myth. They do exist. So similar to that, I'm sure many of you have seen patients who truly had contrast-induced AKI. So this is a CT scan. It's a plain CT scan. It's not a contrast-enhanced CT scan. It's a plain CT scan in a patient who 2 days ago, he had cardiac catheterization. He had coronary angiography. It was a difficult procedure. So the cardiologist injected more than 300 ml of contrast. And 2 days later, the patient came in with oligonuria. They weren't making any urine and they weren't feeling well. So because there was abdominal pain as well, the emergency doctor did a CT scan, and the CT scan shows that the contrast is still stuck in the kidney, right? This is what is called as a nephrogram. Because the kidneys are not functioning, the contrast is not getting excreted. It is lying there in the kidney lighting up. So in this patient, it was clearly contrast which caused the AKI. So it is definitely not a myth. I have seen patients with contrast-induced AKI. I'm sure many of you have. So it is not a myth, but the question is how common it is. And this is another real case, is that this patient had, a creatinine. This is the lower creatinine. It goes from 181 to 250 to 286. Then it stays at about 400, and then it takes another jump to 600. And what happened here is something you may often see, is that on March 10th, the patient had cardiac angiogram, and 2 days later, while the creatinine was still going up, it had gone up from 170 to 250 to 80. The patient underwent a stenting procedure, and it went up to 600. So they had 2 hits with contrast, with repeat procedures, and the creatinine went up to 600. Now, what you see at the end is that creatinine is actually going down to 425 and 395. So this is something which is very common, is that in contrast-induced AKI, the kidney recovers, right? All you need is for that contrast to pass through, and in a few days, the kidney recovers. So in my opinion, again, this is my opinion, but true contrast-induced AKI is often seen in people who have a lower baseline GFR, who get a high contrast load. So arterial is way more than venous. Repeat contrast, like the patient I showed, within 48 to 72 hours. And often it presents with oliguria and a rapid creatinine rise. You will see a creatinine going up within 24 to 48 hours, a very rapid rise in creatinine. And often they may, because if there is oliguria, they may present with volume overload. So as a result of this, they get AKI, but you will often see recovery by 10 to 14 days. And if you don't see recovery, it may not be contrast-induced AKI, and you should consider a kidney biopsy. It's either, the most common differential diagnosis is that it's ischemic ATN, or they could have a cholesterol emboli or AIN or who knows what else. So don't label everything as contrast. If they don't recover in 10 to 12 days, 10 to 14 days, then think about doing a biopsy. Now, why do some people think it is a myth? It's because of these large studies that have been published. This was one of the big ones from Jennifer McDonald at the Mayo Clinic. They did this, very, very large study with thousands of patients. And they did propensity score matching. So they took patients who got a contrast scan, and they took patients who did not have any contrast, and they looked at the risk of AKI. There are many other studies like that, and they have published a huge number of literature, which all seems to suggest that there is no increase in AKI after contrast. Now, I have a problem with this, right? And this is a Canadian paper which used, a slightly more nifty statistical analysis method. The problem is this, that there is an underlying selection bias which cannot be eliminated with this propensity score matching. So think about this. Let's say there is a 75-year-old woman whose baseline creatinine is 3.5 milligrams per deciliter or 300 micromole per liter. So the GFR is about 12. And this patient, how many of you will do a contrast CT scan if a non-contrast CT scan will give you the same information? So these patients, what happens in this observational studies is that these kind of patients are underrepresented in the contrast group, and they are overrepresented in the control or non-contrast group. At the same time, these patients are more likely to get AKI. If they're in the hospital and they're sick for some reason, it doesn't take much for someone like this to develop AKI. They get a little bit dry, they get some hypotension, they get a pneumonia, boom, they have AKI. So they may not get contrast and they may still get AKI. And a propensity score matched study cannot account for this underlying selection bias, and hence it may bias the results towards the null. It may tell you that, oh, contrast doesn't cause AKI, when that truly it does. Now, this is, for example, one study from Andrew Davenport in radiology, and many of these studies, though, they have very, very few patients who had a GFR of less than 30. Most of these patients have a GFR of more than 30. If you look at the number of patients who had a GFR of less than 30, there is truly a signal, right? So there is almost a 3-fold increase in the risk of getting AKI in those who had stage 4 or 5 chronic kidney disease. Now, the numbers are small here, right? So it's look at this, 44 and 72 patients compared to 7,000 patients, 14,000 patients with a GFR more than 60. So 14,000 versus, 110 patients. So that tells you that once the GFR is less than 30, people are not using contrast, which is pretty appropriate, right? If you can get the same information without contrast, why give it? And these effect sizes that we are describing, they are very uncertain. They are based on very small numbers. So, so far, I hope I have convinced you that contrast-induced AKI is not a myth. It does exist, but it's much lower than what we had thought in the past. And low GFR is possibly a risk factor. But what causes contrast to damage the kidney? So, if you look up the pictures or pathophysiology, you will have these arrows going in all sorts of directions. There is medullary oxygen supply, there's reactive oxygen species, or there are these kind of fancy diagrams that have arrows going on in all directions. I would say it's best to go back to that CT scan I was showing you. There is contrast that is stuck in the kidney. So the contrast medium, even the low osmolar contrast, it is higher osmolar than the serum. And it is viscous. It's not just osmolarity that matters. It is viscous, and because it is viscous, it is more likely to get concentrated in the tubules. When the water gets reabsorbed, the contrast does not. So it is it makes the flow of urine very sluggish. It also disrupts the blood flow in the vasa recta, worsening the ischemia. So it is just this physical clogging up of the kidney, to me, that causes this contrast AKI. And that explains why, the kidney function goes down very fast. But also, once this contrast is passed, then the kidney recovers very fast. If there was true acute tubular necrosis, then the kidney is not going to recover in a day or in 5 days, right? It takes, the tubules have to heal, they have to regenerate, and it takes more than 5 to 10 days. Whereas in contrast-induced AKI, you see recovery in 5 to 10 days. It's sort of like an obstructive uropathy, except that the obstruction here is inside the kidney. So, and that makes, that is why the dose matters, because if you've got a higher dose, then that higher dose is going to clog up the kidney. And the same thing happens with arterial contrast. So for example, if you inject, if someone is doing a cardiac catheterization, they inject contrast in the left ventricle or the aorta, it will reach the kidney right away, compared to venous contrast, where the contrast is being injected into the vein for a CT scan. It gets diluted with the venous return from the rest of the body, mixes up, and it reaches the kidney a few cardiac cycles later. On the other hand, if you are injecting it into the coronaries, I'm not so sure that that is worse. If you don't do a left ventriculogram, just intracoronary contrast is probably similar to a venous contrast, right? Because it's going into the right atrium. What else is important here? So, there is a trial actually. So there was a trial which was published in Radiology. Here, they gave intravenous or intra-arterial contrast. So, a CT, coronary CT versus coronary angiogram. And what they showed here is that there was truly more AKI. In the red line, as you see, is the intra-arterial. So there was more AKI. The relative risk was about 2.4 with intra-arterial. Now, the other thing that happens when you're doing an intra-arterial contrast injection, and what they showed here is that the risk factors included doing a ventriculography, which I said, is truly arterial. It is going in the kidney at a high concentration, and femoral axis. So they reported that the femoral axis is worse than a radial axis. Now, why might that happen? So, why would a femoral axis be worse than the radial axis? And this picture shows you why. So this is from the Renal Fellow Network blog, and this is showing a picture of an artery which has got these, these transparent clefts. These are cholesterol clefts. So this is a picture of cholesterol embolism. And that's very likely happening in patients when you are putting a wire in someone who has got atherosclerosis in their aorta, and you can easily dislodge some emboli from the aorta, which may go to the kidney. If you go from the radial artery, it's unlikely that they will reach the kidney. Whereas if you go from the femoral, you're passing the kidney by, and it's more likely to go to the kidney. And that is what probably explains why femoral axis is worse than the radial axis. And it's not causing contrast-induced AKI. It's actually causing atherosembolic disease or cholesterol emboli and kidney injury. Contrast has nothing to do with the AKI in these settings. This is another paper from Japan, where they looked at the atheroma volume. So these were patients who were undergoing a TAVI, a transcatheter aortic valve implantation, and they looked at the atheroma volume, and they showed that the atheroma volume above the kidneys, above the renal arteries, was associated with AKI. But if you see the lower graphs, the atheroma volume below the renal arteries was not associated with AKI. Again, what this shows is that it's not contrast causing AKI in many of these cases. It is a cholesterol emboli that was causing AKI in these patients. So, arterial contrast is worse. We say that, but arterial contrast is not really all contrast-induced AKI. It's a mix of true contrast AKI and atherosembolic AKI or ATN. And again, arterial contrast often is also in the setting of patient who has a heart attack, or they have cardiogenic shock. So that itself can cause AKI, whether they get a contrast or not. So there are other things that are happening with an arterial contrast, which is why it appears worse. What about residual kidney function, right? We often have patients on hemodialysis who are making some urine. We have patients on peritoneal dialysis, especially, who make a lot of urine, and residual kidney function is very precious in these patients. What we did is we looked at a few studies that had looked at giving CT scans or angiography in patients with PD. And what we showed here is that the difference in the residual kidney function slope before and after contrast was really not significant. So it was very, very small, 0.16 ml per minute per 1.73 meters square. So for residual kidney function, it doesn't matter. Now, how should we define contrast-induced AKI, right? So this is a really important study. It was from Chirag Parikh's group at Yale. They looked at this PRESERVE trial, which we'll talk about later, and they measured biomarkers. So they looked at biomarkers of kidney injury, and they showed here that in these patients, there was no increase in tubular injury biomarkers. So really, the tubules did not get injured at all. They are talking about AKI, like the KDIGO criteria. So all these patients had a creatinine that went up, that there was a bump in the creatinine, but there was absolutely nothing in case of tubular injury. So what kind of AKI is happening here, right? This mild AKI really doesn't matter. And you look at the KDIGO AKI stages, that's what people are using now, like, the 0.3 milligrams per deciliter increase in creatinine, or a 50% increase from baseline. My opinion is that this 0.3 milligrams per deciliter is like a for diagnosis, really. It doesn't matter. It's a noise. It picks up noise. It picks up a lot of inconsequential AKI, right? Numbers go up and down while people are in the hospital. And it helps the clinical research people, right? If I'm doing a clinical trial, I get a lot of events. So it helps me get power, but not clinical practice, right? In real life, it's not useful to measure all these numbers going up and down. And maybe because of this noise, it may even hurt clinical research. And it's not the fault of KDIGO. KDIGO followed the Akin and the rifle, and we needed some kind of standardization. But for contrast, I would argue that we need some different kind of diagnosis. And this was a proposal that J.C. Velez from New Orleans and I put together a couple of years ago. Like there are criteria for rejection, there are criteria for infective endocarditis. We are proposing that these criteria may be useful. So the patient has to have exposure to contrast and at least stage 2 AKI, right? The stage 1 we don't care about. And then there are some major criteria. So is the GFR less than 30? But more importantly, are you ruling out all the other things? So when people talk about contrast-induced AKI, they do say rule out other things. But in clinical practice, when people go and see patients, I don't know about you, but my fellows often come and tell me, oh, this patient had contrast and they've got AKI. And I say, oh, but weren't they hypotensive? And don't they have sepsis? And aren't they on antibiotics? So what about all those other things? Why are you blaming the contrast when there are so many other reasons they could have AKI, right? So specifically look for all these things. I often like that, if you see a nephrogram or if there is oliguria, there is high dose contrast. There are also, additional circumstantial evidence. So these kind of things may help. Again, this is just a criteria that we made up. It's not validated. It's not approved by any guidelines or any committees. But I think this is how you should be thinking when you have a patient and you're thinking of AKI and whether contrast is to blame. So again, to summarize, contrast does not damage residual kidney function. Most mild AKI after contrast is noise. It's mostly hemodynamics and it's inconsequential. And if you make a diagnosis of contrast-induced AKI, it is not a myth, but make that diagnosis carefully. It's a clinical diagnosis, not just on the basis of numbers, right? All these observational propensity score match studies, they don't know about the clinical diagnosis. They're just looking at contrast and AKI based on the medical records. So don't do that. Make a clinical diagnosis very carefully after making sure that you have ruled out everything else. So now you've got AKI. How do we prevent AKI? Now a patient is getting contrast. So let's go back to this CT scan that I keep showing you again and again. There is contrast stuck in the kidney. So it is highly osmolar. It is viscous. It gets concentrated and it gets stuck. So would volume expansion help? Would it dilute the contrast and make it easier for the kidney to get rid of it? Maybe not. So this was a trial called Amazing done in the Netherlands. They took patients who had a GFR of greater than 30 and they randomized them to getting intravenous volume or nothing. And as you can see here, in all these subgroups also, there was absolutely nothing. 8 patients in each group. And again, this tells you how uncommon AKI is. So only 8 patients in each group got AKI, but there was no difference whether someone got volume or did not. So in those with GFR of 30, Amazing showed that it didn't work. And this was another one, again, Dutch study published in JAMA Internal Medicine. They used sodium bicarbonate, again, no difference at all, whether you used volume or not. Now, both these trials were in patients with a GFR of greater than 30. What about those with GFR of less than 30? There's no trial of hydration versus no hydration with GFR of less than 30. So right now we do give hydration with GFR of less than 30. And this is what we use, right? So the PRESERVE trial looked at using normal saline or sodium bicarbonate based solutions. And they showed that there was no difference between saline and bicarb. So if you want to use saline in a patient with GFR less than 30, that's perfectly fine. Of course, I would argue that this was a systematic review we did a decade ago showing the same thing, that there is no difference. But, these were smaller trials, and we needed a large trial published in the New England to tell us that saline is just as good as bicarb. Now, it's not always easy to give IV saline, right? If a patient is going for a CT scan, you have to bring them to the hospital to give them intravenous saline. So can you do it with oral salt and water? After all, it's the same, right? Like, why do you want to put an IV in when they could just drink some salt and water? And this is a small systematic review we did, which shows that, oral salt and water might be just as good. But again, these are small number of trials. We had only 5 trials and a small number of events. But it does show that maybe having a proper protocol of, not just drinking water, but having salt and water is important in this case. So in terms of prevention of CI-AKI, no volume expansion is totally acceptable if the GFR is greater than 30. Below a GFR of 30, whether you use saline or bicarbonate, it's totally fine. If you can give IV, sure, go ahead. If IV is hard to arrange, give oral salt and water. And to be honest, I think no hydration also may be acceptable for IV contrast for CT scans below GFR of 30, right? If it's low risk, if it's an outpatient, I'm not sure that we really need to do something. It's just that no trial has established that this is safe, hence we say do IV hydration. What about doing dialysis after contrast? I don't know if you guys get called for it. We used to get called for this very often, saying, oh, the dia has been injected. Can you dialyze it off? And that's like so foolish. Because if the contrast is going to cause kidney injury, it has done it already, right? By the time you put a catheter in and take the patient for dialysis, 5 hours have passed and the damage is done. But if you want a trial, there is a trial which shows that, doing hydration versus dialysis makes no difference. What about safer contrast media, right? There are high osmolar contrast, which is diatrizoate, iothalamate, iodamide. So those are no longer used, at least in Canada. I don't know if these are still used over there. Most people have moved on to low osmolar or isoosmolar. Now they call it low osmolar, but if you look in the third column here, even the low osmolar have an osmolality that is about twice that of serum, right? So it is not really lower than iso, but it is low compared to high osmolar. So we do know that low osmolar is safer than high osmolar, but what about low versus iso? Does it make a difference? Honestly, I don't think there is much of a difference between ionic and non-ionic, but between isoosmolar and low osmolar, there is some controversy. So, there are many trials and there are many meta-analysis, and this is the key aspect here. So this is one meta-analysis, and if you see there is a lot of heterogeneity. What that tells you in this meta-analysis is that some trials are different than other trials, and you should be careful in interpreting this evidence. And what they did is they looked at iodixanol versus iohexol, where it seems that iodixanol is better, which is the isoosmolar. And they look at all other low osmolar, and it looks like iodixanol is no different than other low osmolar. Now, this is all because of this single trial by Aspelin, this big black box that you see in the bottom right. That is the trial which was stopped early, and that drives all those results. To be honest, I don't think there is much of a difference between low osmolar and isoosmolar. So whichever is cheaper, that's what you should use. So to go on with prevention of CI-AKI, dialysis is silly and futile just for preventing AKI. Isoosmolar is similar to low osmolar. There is, in my opinion, there is no difference between the two. Use whatever is the preference of your radiologist, cardiologist, or cost. What about holding nephrotoxins, right? One of the big ones is metformin. So metformin is not nephrotoxic. We know that it's not nephrotoxic. Its predecessor, fenformin, was banned because it caused lactic acidosis. Metformin doesn't directly cause lactic acidosis, but there are a few case reports of this as well. On the other hand, the chances of it causing lactic acidosis are higher when the kidney function is low and when the patient is in shock, right? And they cannot metabolize the lactate. So if a patient is on metformin and they are given contrast and then they develop AKI, and at that time you forget to stop the metformin, then there is a possibility of lactic acidosis, right? So it's like you need a string of events to happen for metformin to cause lactic acidosis. So all these drug labels, they talk about, oh, you have to stop metformin before 48 hours before getting contrast. It's really, there is no science behind it. we don't bother doing that. On the other hand, if your patient's GFR is less than 30, metformin maybe should be stopped anyway because the side effects are higher. So one should be careful from that aspect. What about stopping ACE inhibitors or ARBs? There is a trial and it shows that there is no difference between 14 patients got AKI here and by discontinuation 8 got it, and the difference was not significant. So the benefit, if at all, of stopping ACE inhibitors or ARBs before a CT scan is also very low. So there is no point in holding RAS blockade, metformin, and I didn't show diuretics, but it's the same thing, right? So if the patient is volume overloaded, make sure you continue the diuretic. On the other hand, if they are dry, you stop the diuretic. Don't give it or stop it just because they are getting a scan. There are many other things that have been tried that don't work, including theophylline, mannitol, trimetazidine. Statins is very interesting. There is some evidence that statins may be beneficial. What I would say is that if your patient, has undergoing a cardiac cath, they should be on a statin anyways, not to prevent AKI, but to prevent heart disease, right? And CKD patients are at high risk of cardiac disease, so give them statins. Don't give statins just to prevent AKI, give them statins for cardiovascular prevention. So to end with some practical suggestions, so we have some time for discussion at the end. What we do, again, from a radiology perspective with CT scans, we would suggest only identify GFR less than 30. And once you know the GFR is less than 30, you make a very conscious decision to use contrast. So it's not that, why not inject contrast? If a plain CT is enough to make the diagnosis, there is no need to inject contrast. But if, let's say we are talking about liver metastasis or something like that, then you really need to have the contrast. So, in that case, don't not give the contrast and have a non-diagnostic scan. I think liver metastases are more important as a diagnosis to make rather than, the small risk of AKI. And if you want to do something for prophylaxis, oral salt or water or even nothing, in my opinion, is acceptable as prophylaxis in this setting. What about follow-up, right? So should you call all these patients back and check their creatinine in 2 days? Again, it will create a lot of noise. Do you want to measure creatinine in all these patients? We don't. We in fact say we give patients some advice saying, hey, if you become short of breath, if you stop passing urine, then come to the emergency. Otherwise, you're fine. If you start measuring creatinine in everyone, you will pick up a lot of noise and you're creating a lot of nuisance for everyone with no benefit per se. So we tell people do not measure creatinine, but if you have symptoms, then, seek medical attention. What about the emergency room, right? So you have a patient who is sick. They are having, maybe you're suspecting abdominal sepsis. You're thinking maybe they have a ruptured aneurysm. You're thinking, they have got a stroke. Should you delay the contrast until the creatinine result is available? And sometimes, people even ask for a nephrology consult, and I would say absolutely not. Don't do that, right? If a patient is sick and for some reason they need a contrast dye, then just give them the contrast dye. Right, we can deal with the AKI as nephrologist after it happens. And this is a nice debate that you can read. It was published last year, where a couple of nephrologists and a bunch of emergency doctors came together, and we debated both sides, saying, hey, you should wait or you should not wait. And it's freely available if you want to read. So these are some references that I have put there. I hope that they will be useful for you to see. But and again, the slide set will have these references. If anyone has any questions, you can ask them either on Twitter or they can email me. That my email is up there. We run this nephrology journal club on Twitter called NephJC every 2 weeks. You can check our website out as well at www.nefjc.com. We also have a podcast called Freely Filtered. So if you listen to podcast, then you can subscribe to Freely Filtered, where we talk about these things. So at this time, I'll just put up the summary slide and we can have some Q&A. If there is time, I can show some other slides as well, of course. So in summary, contrast-induced AKI is uncommon. It should be a clinical diagnosis, not a biochemical diagnosis based on change in creatinine and contrast exposure. And post hoc is not propter hoc. That is, every AKI after contrast is not because of the contrast. Prophylactic measures should only be used in certain settings, when the GFR is low, when you're giving arterial contrast, or, you're anticipating a large contrast load. And prophylaxis, only volume expansion is all that matters to me. Everything else is futile. when contrast imaging is really needed, right? You're thinking of cancer, some vascular disease. If the patient needs a therapeutic interventions like an angioplasty or something for stroke, do not avoid contrast for fear of AKI. That's the last thing you should be doing. So if there is one take-home message, that's summarized in this slide. So I'll stop the screen share, and if there are any questions, we can look at the chat and answer them.
Dr. Swapnil, that was excellent presentation. Thank you very much. Yeah, so as you clearly mentioned, it's a time for questions and answers. Maybe I should start by this question. During your presentation, you clearly stated that, doing, dialysis after contrast being given to the patient doesn't really help. But for the cardiac procedures, they will always call you, saying you have to do something because, you have given contrast. So I just wanted to know, how long does it take for the contrast to cause damage to the kidneys? Because if it is it immediate? But if it is, it takes time, then probably the HD will help.
So there is one paper from Italy by Dr. Marenzi. What they actually did is they did CRRT. So they did continuous veno-venous hemodiafiltration. And they started almost immediately. They had a catheter put in even before the patient went in for the contrast procedure. So that's how fast you need to be. And I'm not sure I believe those results because, no one else could replicate them. What you have to think about is if the patient needs dialysis anyways, right? If it's a dialysis patient and they are in volume overload or something, then sure, do dialysis. But if it is a patient who is not on dialysis, who is getting a cardiac cath, to do dialysis and remove that contrast, what you will have to do is you will have to put in the catheter. So there is some, complications associated with that may happen. And then you have to do dialysis, which is, not a benign procedure as well. So you're exposing the patient to a catheter insertion, dialysis, and maybe there is a small decrease in AKI, if at all anything. But secondly, your point about the rapidity is very important because the contrast goes into the kidney, in the first cardiac cycle. In milliseconds, it is gone to the kidney. Even if the damage takes time, you will remove the contrast from the circulation. You will not remove the contrast that is already in the kidney causing damage, right? Unless you had a way of putting a catheter into the kidney and sucking all that contrast out magically. By doing, even if you get it within an hour or 2 hours, removing the contrast is not going to be that helpful. And trials have demonstrated that it is not helpful. So I'm on the camp where thinking that dialysis doesn't help in decreasing the risk of AKI in patients who are not on dialysis. In patients who are on dialysis, if it's convenient, you can arrange their dialysis schedule such that, their dialysis is after their contrast procedure. But that's more because often these patients run into volume trouble, right? With all the volume that is injected into them, rather than, trying to prevent AKI.
All right. Thank you very much. So can I hear some comments from the panelists, if any?
There are some questions in the chat that I can answer if it's okay.
Exactly. Please proceed. Yes.
So there is a question about as a nephrologist, do you need to have prior communication with the radiologist when making decisions for CT with contrast? And this is a really, really good point. So it's one thing for you to say, it's me, you can say, oh, I heard this lecture saying that it's fine to give contrast, but you have to convince your colleagues about the logic, right? So this is very important that at your institution or with your, in your network, you make sure all of you are on the same page. And there is no easy way about this, right? So we had over a period of 2 or 3 years at my hospital, we had a series of meetings. We had emergency doctors, we had the radiologist, and it was us, and we kept meeting, and we went through all these scenarios about how should we do this, how should we do that. And we showed the data. So it wasn't just, me telling them, but we heard everyone's opinions, and we came to this, consensus saying, hey, this is what we will do. So you need to establish that, because otherwise it's going to be, hey, why is this doctor saying give contrast or don't give contrast? So this is not, this is the boring part of medicine, but you have to do it, right? You have to have these meetings. You have to talk to everyone and make sure they understand why you're saying something and why you're saying something else, right? And it's like we were talking about MRI earlier before it began. With MRI, it's different, right? With MRI, we still say don't give gadolinium in dialysis patients. We say you should do dialysis after gadolinium and all that. Whereas contrast is different, right? So sometimes it's confusing. So it's really important that you should have a back and forth with your radiologist, and all of you should be on the same team. Again, it's not easy. It takes a lot of work, and sometimes, you have to keep saying the same thing all over again, saying, no, they do not need dialysis. No, they don't need mucomist. They don't need this. They don't need that. It's okay to do this. It's fine if you give low osmolar, but you have to keep reiterating this kind of information again and again. There's another question from Dr. Elijah on what is high dose contrast load. And this is a little bit tricky. So there are some papers which describe some formulae, right? Like you have the creatinine clearance and you have the contrast amount. To me, anything more than 150 ml is high dose. And we encourage people to say, don't use high dose. But when I talk to my radiology friends and I said, at one of these meetings, and I said, don't give contrast high dose. And they laughed at me. They laughed at me because they said, we are not giving more contrast just because, I want to have a pretty picture. We have a set protocol. If I'm looking for, metastasis, I need to give this much amount of contrast. I'm not going to give more, or I'm not going to give less. If I give less, I may have a non-diagnostic scan, right? Then the image quality is not good, and they may not be able to tell you if there is metastasis or not. So it's easy to say don't give high dose contrast, but to practice it is not that easy. Yes, if you're doing a cardiac cath and if the patient has a GFR of less than 30, you should tell the cardiologist, right? Use the least amount. Don't do a left ventriculogram if it's not necessary. If it is a complicated procedure, maybe, abandon. The patient that I showed who had 300 ml of contrast, what happened is that he had a bypass surgery before, and the graft was hard to cannulate. So they kept injecting dye here and there to find the graft to cannulate. And what they could have done perhaps is they could have bailed out and said, hey, we can't do it right now. Let's stop. Let's bring the patient back in 2 weeks and then, let the kidney clear it. So that's how, for procedures like that, if it is an option, then it's okay. But there was one situation where one of my patients had a fistula which ruptured. It was aneurysmal, and the vascular surgeon and radiologist had to inject a lot of contrast. This was a transplant recipient who had an old fistula, and they used, I don't know, 300, 400 ml of contrast, but that was necessary because if they didn't do it, the patient would have bled out and died. So again, it's easy for us to say don't use high dose contrast load. I think it's useful when you get AKI and you look back and there was a high dose, then you can say, oh, this was probably because of contrast. But in terms of being actionable, it's not very useful. Dr. David Atuhe asked is contrast dialysable? Anyway, it is. Unfortunately, it would have been nice if it wasn't. It can be removed easily with dialysis. So that's not a concern. The question is there any point, removing a little bit of contrast? There's a question about overall, we should not postpone contrast study if the surgeon needs it emergently. But we are concerned about advanced CKD patients tipping over into ESKD. And that is true, right? I was saying that most of the contrast-induced AKI is reversible, right? So people will get AKI, but in 5 to 10 days, in 10 to 14 days, they will recover. Now, if someone has a GFR of 10 or 11, that may tip them over, and they have such few nephrons left that are functioning that if the AKI happens, then they may not, the kidney may not be able to come back at all. The tubules are damaged. So in those patients, yes, you should be concerned. And then you have to think about those are the patients that I think we should be involved, right? We should see these patients. You should not just say, hey, yeah, go ahead, use contrast. And you look at the patient, you decide if contrast is really necessary. Will an ultrasound, a Doppler, or a plain CT or an MRI with no GADO, will that be enough? If it is going to be enough, then do that. But, if they do need to have contrast, then tell the patient that, hey, there is a small risk that you may, end up on dialysis. But really this diagnosis or this intervention is really important. So are you okay with us going ahead? So those are the most difficult cases. And in those cases, we should be involved, and we shouldn't be like, oh, it's a myth, it doesn't exist, or, don't give contrast at all. You need to have a shared decision making, talk to the patient, weigh the risks and benefits. It's, old-fashioned medicine that we have to do sometimes. So John Caroli asks about the treatment of AKI. Like most of medicine and nephrology, there is nothing really specific for contrast-induced AKI. If it has happened, it's mostly supportive management. You wait and you treat, you do dialysis or what have you. And if it's going to get better, it will get better. The only point that I keep saying again and again is that if in 10 to 14 days, if the patient does not recover, then I would do a kidney biopsy, because you may be missing something else, right? There was one situation I had where it was AIN, interstitial nephritis, and we gave the patient steroids and they recovered. And otherwise, if I would have labeled it as contrast, we would have missed that. So in about 2 weeks, if they don't recover, you should do a biopsy. Otherwise, there is no specific definitive management. And there's a question from Dr. Mazhar Amirali about the volume of salt and water pre and post contrast. So I wish there were good studies about this. What we have done as in practical terms is tell patients to have a bowl of salty soup the night before the contrast scan, so that their volume expanded, and early morning as well, before on the day of that contrast, and then to have more salty soup after the contrast procedure is done. So 2 or 3 bowls of chicken soup or something along those lines is what we recommend. Otherwise, think about the IV saline, right? So it's about, it's just a small amount that you give. These protocols for IV saline, they have about 250 ml before and about 250 ml post contrast. So it's about half a liter. That's all. So there is no reason why you could not encourage the patient to take, half a liter of water or half a liter to 1 liter of water along with, some salt. It's not water, they call it hydration. I would prefer salination. So it's not just hydration, and make sure you encourage, eating salty food before and after. Yeah, I think we covered the other nephrotoxic drugs, NSAIDs and aminoglycosides. Sure, those drugs are truly nephrotoxic. Again, we don't have any evidence. If they are not needed, for sure, hold them. It's okay to hold NSAIDs and aminoglycosides, but if the aminoglycosides are being given for infective endocarditis, then you better not hold it. And if it's given appropriately. And renal, there's a question from Dominic about distinguishing renal atherembolism from contrast nephropathy. So this is a really good point, right? A lot of these patients truly have cholesterol emboli. So how do you differentiate? Well, you can look for signs, like trash feet or something where they have signs of cholesterol emboli into the feet. If they have that, that's sort of circumstantial evidence. Otherwise, really, there is nothing. Clinically, what I have seen is that the creatinine goes up faster with contrast than with atherembolic, and they don't recover with atherembolic, right? So, in 10 days, when I'm saying you should do a biopsy more than AIN, I'm talking about picking up cholesterol emboli. So a biopsy will differentiate between cholesterol emboli and disease like this. Some people have described eosinophilia, but again, that's not a very sensitive or specific sign. You can argue that, there is no treatment for cholesterol emboli. So what is your biopsy going to achieve? It's true, your biopsy is not going to change management, except for the occasional, AIN or something else that you can pick up. I'll come back to the acetylcysteine question later. The podcast for Freely Filtered, you can just Google Freely Filtered podcast, and there is a link, or I can put it in the chat box after we are done with a link to the podcast. There's a question from Dr. Low Jones about getting consent form. Yeah, the radiologists want nephrology consult for scans. That is such a painful issue. And this is why, I said those meetings are useful, because we used to get a lot of these before. And then once we got on the same page, we sat down and we said, hey, this is what we think it is. Then we agreed. The concern here is, from try to think from the radiology perspective. They are the ones who are giving the contrast dye, and they, then the patient gets AKI, and then they will get blamed, right? They gave the contrast, and that's why the AKI happened. So they did something bad. That is why they are nervous about this. So, as long as your group says, we are not going to blame you, if there is AKI, then they will have reassurance that this is not going to be, bad things can happen, right? If the contrast was truly necessary, you have to make sure your team, the radiology team are judicious about using contrast. They're not, like cowboys giving contrast when it's not needed. But once you have that kind of a setting, then there would be trust that develops between the two teams. This is less about the legal aspect. And again, I don't know if things are different at in your setting than for us, but more about, how the colleagues get together, and is there trust, or is there an environment of blaming each other? We don't get consent from patients at all. I think it's, how can the patient consent, right? What do they know? They know what you're telling them. So we don't get consent, but we do have the discussion and we document the discussion. I don't think it's necessary to get a consent, but the discussion, like I said, is in patients with, advanced CKD, whose GFR is, less than 30, maybe less than 20 or 15 even, where I think if the chances of getting AKI are high, and then you want to be involved anyways, right? So that you can deal with the problems and it beforehand. And you can explain, I think as nephrologists, we can explain the risks and benefits of the contrast better than the radiologist can. The radiologists, they're not clinicians, really speaking. So, it's hard for them to say, hey, what is the significance of the AKI? What is the importance of this CT scan? Or so what have you. So I think it's appropriate for us to be consulted in those, advanced CKD. But I wouldn't, be keen on getting the patient sign off. And again, meeting them and making sure everyone is on the same page with is more important. On Dr. Lomatoyo's question about ringer lactate, yeah, ringer lactate is fine. It doesn't have to be saline. Whatever fluid you're using is fine. I think salt is more important because this is about volume expansion and not hydration. It's the salt that is really important when it comes to, dilution of the contrast more than water. But again, if you want to have, if you want to do that kind of a trial, we could do that. Dr. Bhima is asking about using contrast in neonates with a GFR of 20 to 30. I'm not a pediatrician, so I'm not sure I'm the right person to comment on that, but it is a tricky issue, I'm sure. And again, in general, what I would comment is the question is about the risks and the benefits.
Yeah.
What is the benefit of the scan versus the risk of the contrast? I think the amount of contrast that you would be needing would be also very, very minuscule. I'm not a pediatrician or a neonatologist, but I'm sure the risk is also very high in these, young undeveloped nephrons.
Sorry, I'm from South Africa, so I just want to introduce myself. I'm Jidnara Bhima. I'm a pediatric nephrologist. Sorry.
Yeah, no worries. That's okay.
I just wanted to say that, I had this is a personal experience because one of the neonatologists gave me a call and said, we have to do a contrast CT on this neonate. And what do you think about giving contrast? Because they had some tumor or something they wanted to diagnose. And I'm just thinking about your talk and the low GFR. I mean, I said it's fine because, look, if it's a normal kidney, you understand? I mean? And we hydrate the patient, gave the patient some volume, beforehand and send the patient for the scan and then again hydrate the patient. But there was no problem. I mean, the creatinine remained the same. So the thing is, I just wanted to know if there was any higher risk and then what would be.
Yeah, no, we haven't had, again, as you know, pediatric studies are even rarer than adult studies, and nephrology studies are even less. So if I'm getting it right, neonates, that normal GFR is like this. Am I right?
Yeah, it's
exactly. So what else can you do, right? If you're absolutely right about this, that if they need the scan, they have got a tumor, you have to do the contrast. That's the right thing to do. Maybe the risk is higher, maybe it is not, but the diagnosis is more important in this situation.
Thanks for that excellent talk. Thanks a lot.
So I didn't get to a couple of questions. One question was on the N-acetylcysteine or mucomist. I do have about 10 extra slides that are there. If there is time, I can show them, or you can look at them later when they're circulated. But the PRESERVE trial looked at this. Pardon?
Go ahead.
Okay. Let me then show those slides again. This won't take long. So the story of I hope you can see this. So the story of NAC is very, very interesting, for me at least. So this is mucomist or N-acetylcysteine. You see this has got a sulfur group, and the sulfur group is how it donates that sulfur group, which helps in regeneration of glutathione. So it's an antioxidant. Now why did we use it in contrast? So this was a small trial which was published in the New England, which showed that giving contrast, there was less AKI, right? So on the left you can see all these patients whose creatinine went up, but those who got N-acetylcysteine, very few people got a rise in creatinine. So it became very popular to use N-acetylcysteine. But if you look at the definitive evidence, in about 10 years later, this was a large trial done in Brazil with 2,300 patients. And it showed that in patients with intermediate risk undergoing coronary angiography, if you looked at the risk of death or need for dialysis, there was no difference at all. Again, you can look at it in many different ways, but there were plenty of events. There were about 300 events, and there was no difference. In the previous study, in TEPEL study, the total number of patients was 80. In this case, it was 2,300, right? But this was not published in the New England. It was published in Circulation. And then the PRESERVE trial came. This had 5,000 patients. And you can see here that, with N-acetylcysteine or placebo, there was no difference. About 4.5% patients had AKI. This was the, data on N-acetylcysteine. So it clearly does not work. But why was this a confusion, right? Why was this, maybe it works, maybe it does not work, right? Why is this mixed evidence? And this is a really, really nice study published in BMC Medicine in 2007, way back when. What they did is they looked at all the studies, and these were the kind of studies, right? So the study on the top in the forest plot is from TEPEL. That was the one published in New England. And then there were all these other studies. Some are positive, some are negative. So why is this data mixed? So, they looked at, at what was causing this heterogeneity. And it looked like there were these 4 studies on the top that if you put them in, they made the, analysis very heterogeneous. And removing those trials decreased the heterogeneity. This was all, statistics. And what they saw here, though, is that in these 4 trials, what was happening was that N-acetylcysteine or mucomist actually reduced creatinine. So just think about this for a moment. If you have a drug which prevents AKI, in those patients, the creatinine should not go up. But you're not expecting it to improve the kidney function and decrease the creatinine. But that is what was happening in these 4 studies, that the creatinine actually went down. So there was something very fishy going on here. Nothing that the trialists did, but something fishy was going on. And this is another meta-analysis that we did. And we looked at the studies and we showed that in people, this was not in patients getting contrast or anything like that. This is just normal people who were given NAC and they measured serum creatinine versus placebo. And we can see here that NAC reduces creatinine. So for some reason, N-acetylcysteine reduces creatinine. Now, why might that happen? And when we looked at Jaffe versus non-Jaffe methods, the decrease with the enzymatic assay was much more than with the Jaffe reaction for measurement of creatinine. So again, this is kind of getting deep into the weeds. But as nephrologists, right, there are these 2 ways of measuring creatinine. So what's going on here? So in the absence of contrast, NAC does reduce creatinine if measured by enzymatic assay. So should we give NAC to everyone? Does it protect the kidney? I don't think so. What we did here is that we took blood in a test tube and we added NAC. Okay, this was not, real patients. This was just blood in a test tube. So in our test tube study, what we showed is that in the enzymatic assay, the more NAC we added, the more the creatinine decreased, right? So whether the creatinine was normal or slightly elevated or even more elevated, adding more and more NAC caused more and more decrease in creatinine. And this was not seen with cystatin C, and this was not seen with the Jaffe method. So there is something going on where N-acetylcysteine reduces creatinine if you measure it by the enzymatic reaction. It's just a lab artifact. So what might be happening? So if you look at the enzymatic reaction, it's an oxidation reaction. It requires peroxidase there. So is there any surprise that if you're using an antioxidant there, that it would interfere with this reaction. So NAC interferes with these reactions in a dose-dependent fashion. So it doesn't do anything in the patient's body, but a little bit of NAC in the blood makes your measurement of creatinine, it affects the measurement of creatinine. So, you know, if you go back to that first trial that Teppel showed in 2000, even here, you know, you see what happens to the creatinine. A bunch of these patients are having a decrease in creatinine. It's not that their creatinine is remaining flat. It's that their kidney function is actually improving, so-called improving, not really improving, but the creatinine number is decreasing. So that's what was happening with NAC. And why does this matter, right? So I think for 2 decades, we were misled. I have used Mucomist in the early 2000s to prevent AKI. And I'm sure many of you have used it. We did not know how contrast causes AKI. We did not know how NAC works, but we believed that first study and we were start using NAC. I'm sure some people are still using it. NAC is still used in acetaminophen or paracetamol intoxication, where it makes sense. But in some places, you know, this picture is from India, where NephroSave is a preparation that is available to protect the kidneys. It contains taurine and acetylcysteine. And if you use enough of this and you measure the creatinine by enzymatic, you may see a decrease in creatinine, but actually it is not protecting the kidney. It is just fooling you by making the number look lower. You know, so that's the reason we saw this with NAC. It was just completely, totally a misleading artifact that NAC so-called improves the creatinine, but actually it does not improve the creatinine. It makes the creatinine number look better. So please do not use Mucomist or N-acetylcysteine for kidney protection.
All right. So that's very good. Thank you. So that's
I hope that was useful. I'm a little bit passionate about these topics and I keep talking. So I hope this was useful.
This is very useful. Very, very useful. Thank you.
Wonderful.
Yeah, that's wonderful.
Wonderful. A lot of concepts are changed, are changing at least. Just salination is extremely good. There's no need to do dialysis, not to really feel independent in using contrast when you really need to use. I mean, it's very, very useful. And I think it's a good idea to talk to radiology on these matters and make it clear to them and you know, a mutual discussion so everybody understands. Very, very enlightening. Thank you so much, Dr.
Thank you. Thanks for having me.